So good evening everyone. So as a- so we have a go ahead for audio with the audio and video. So once again, good evening everyone. Myself Dr. Rijul Agarwal. I'm the orthodontic faculty at DAMS. So unlike the previous session, now the date for the exam has come. So as students were asking in the last session when it will be there. So it's now 19th of April. The pattern and all are mentioned in your prospectus. Do read it carefully, take your time and fill the form. Okay, because it's a very important exam. Do not be in a hurry or haste for filling the form. Okay, so we have a session today on the oral habits. In the upcoming sessions, that is after this, I'll be taking up discussions on based on MCQs. So enough with the theory. Now we'll shift our focus towards multiple choice questions and how to answer them. Okay, so beginning with the today's session. So the session today is on oral habits. Okay, so before beginning with it, we need to understand a few important points or the basics of this. First of all, the maturation of the oral functions. So there are two oral functions. First is swallowing, that is eating, and next respiration. So during the fetal life, the respiratory movements in utero are seen in utero, but the lungs don't inflate. Okay, that is at in the time of birth, the newborn infants are obligatory nasal breathers. They are not mouth breathing is not possible at the time of birth. So when does it becomes possible? It becomes possible in later life when the threshold for breathing or the requirement of oxygen increases. We'll see that at what point the threshold limit is crossed. Next, the swallowing occurs during the last month of fetal life. Okay. And lastly, the maturation of the oral functions occur in anterior to posterior gradient. One very important point for your exam. Unlike the cephalocaudal gradient of growth, where the maturation occurs in the head region first and proceeds downwards, as that is the caudal region. In the oral functions, the maturation occurs from anterior to posterior region. Next are some classifications of habits. First classification was given by William James, that is he classified it into useful and harmful habit. Kingsley classified it on the basis of nature of habits as functional, means mouth breathing, muscular habits like tongue thrusting, lip or cheek biting, combined muscular and function like thumb and digit sucking, and postural habits like face leaning on the hand. Ernst Klein classified it as intentional or meaningful, that is with underlying psychological cause, and unintentional or empty, that is no need for support, can be easily treated by reminder appliances. Finn and Sip classified them as compulsive and non-compulsive habit. Compulsive means which are led to some emotional disturbance leading to indulgence in certain habits. Next is this classification. Okay, this became important after your previous NEET 2024 exam because of this masochistic or self-injurious habit. So this classification table is from the book of Shobha Tandon, okay, who classified it into obsessive and non-obsessive. Obsessive is deep-rooted and non-obsessive is easily learned and can be dropped. So obsessive can be classified into subclassified into two categories, that is intentional or meaningful, or masochistic or self-injurious habit. Intentional or meaningful habits are nail biting and digit sucking, and masochistic or self-injurious habits are, example is gingival stripping. Okay, non-obsessive are unintentional or empty habits like chin popping on the abnormal pillowing, and functional habits like bruxism, tongue thrusting or mouth breathing. So beginning with the first, that is thumb sucking, also known as non-nutritive sucking. Okay, Afterwards, we'll have a habit known as tongue thrusting or nutritive sucking. So, what is thumb sucking? That is, it involves placement of thumb or one or more fingers at varying depths into the mouth. Along with there is a strong buccal and lip contractions of the muscles. So, what will be the effect of thumb sucking? So, as you can see, if you can remember this diagram, you can easily understand the effects of thumb sucking. So, what will happen when the thumb is pushed? It will have pressure on the incisor, leading to the proclination of maxillary incisor. Simultaneously, due to the base of the thumb impinging upon the lower incisor, the lower incisors will get retroclined. Next, constriction of the maxillary arch. Why? Because of the depression of the tongue. Now the tongue is depressed because of the presence of the thumb inside the oral cavity. So the musculature, the surrounding buccal and oral musculature, the buccinator mechanism is disturbed. So it will have an abnormal effect and leading to, and this effect or the imbalance in the musculature will lead to the constriction of the maxillary arch. Next is anterior open bite. Why? Because of the interference of the eruption of incisors and excessive eruption of the posterior teeth. So when the thumb is protruded or put inside the mouth, the lower incisor will fail to erupt, and at the same time the posterior teeth, there will be a gap, and due to that gap the posterior teeth will erupt into that space, leading to anterior open bite. Next is, because of this development or supra-eruption of posterior teeth, there will be rotation of the mandible in the downward and backward direction, leading to increased lower anterior facial height or vertical will increase. Now, next, the anterior open bite may lead to the development of tongue thrusting, hypotonic upper lip and hyperactive mentalis activity because of proclination of upper incisors. All the above effects will lead to a long face and a convex profile. So these are the images of a tongue thrust patient, or sorry, a mouth thumb sucking patient. There is anterior open bite, proclined upper incisors, retroclined lower, and because of the presence of anterior open bite, there is development of tongue thrusting in the anterior region. Next, certain skeletal effects. So there will be a narrow nasal floor and a high palatal point. The lip will become incompetent. There will be hyperactive lower lip. Why? Because since the elevation of by the contraction of the orbicularis oris and mentalis muscle to a position between malleus incisors during swallow. So see students, the upper incisors I have told you are proclined, okay, leading to incomplete mouth closure. So during swallowing, as we know, there should be a mouth closure should occur. So if the absence of closure of the mouth, the lower lip has to take that hyperactivity so as to provide the proper lip seal. So for the proper lip seal to occur, the lower lip becomes hyperactive so as to provide optimal position for swallowing. Next is lower tongue position. As I have already told you, due to the presence of thumb inside the mouth, the tongue gets depressed. So this is a flow chart or the sequelae to understand the procedure or the sequelae of thumb sucking which I have just mentioned. So what happens when the child places the thumb between the teeth? There is a development of a negative pressure within the mouth and the tongue starts to get lower. So what will happen? The tongue is lower down, there will be abnormal activity of the cheek musculature. So there is pressure against the upper anteriors leading to their proclination, and then there is a cheek pressure against the upper posterior leading to development of crossbite. So the increased activity of the buccinator mechanism in the absence of opposing tongue muscle forces leads to the development of a V-shaped maxillary arch along with a high palatal vault. So narrow arch and high palatal vault. Next, what are the pathophysiology of the thumb sucking habit? So, up to the age of 4 years, it is considered normal. So, less than 2 years, the thumb sucking plus bottle feeding is normal. From 2 to 4 years, if the thumb sucking continues, it is due to some emotional underlying disorder like inadequate love, caring, and attention. Beyond 4 years, it is considered abnormal. So, another important point for your MCQ: if the age of the child is less than equal to 4 years, no intervention is required. Okay. So what will be the pathophysiology? As I have told you, lower and backward tongue posture leading to exaggerated buccinator activity during sucking and swallowing, constricted maxilla and a buccal crossbite leading to lowered and backward mandibular posture. Simultaneously, what will be the dental effects? There will be proclined and spaced upper incisors, hypotonic upper lip and lower lip trap leading to incompetent lip. Okay, and lastly, a retained infantile swallow leading to development of tongue thrust. So what will be the management? So I have already told you up to 3.5 to 4 years it's considered normal. Now there are certain psychosexual theories related to the etiology of thumb sucking, like the Freudian theory, the oral drive theory, the Benjamin theory, that is the presence of rooting and placing reflex. Thus there is some psychological aspect and learned pattern, and lastly the oral gratification theory given by Sheldon. I'm not going to discuss them in detail. Okay. Next, the classification of thumb sucking. So according to Cook, he classified them into alpha, beta and gamma group. So alpha groups are the one who pushes the palate in a vertical direction and displays only small buccal wall contraction. Beta groups are the one with strong buccal wall contraction and a negative pressure on the oral cavity to show posterior crossbite. Gamma group, there is alternate positive and negative pressure which has the least effect on the anterior occlusion. Septenli et al. Classified them based on the amount of thumb progression inside the mouth. So in group 1, when the thumb is inserted in the mouth considerably beyond the first joint, which occupies a large area of the hard palate pressing against the mucosa and alveolar bone. Group 2, the thumb extends into the mouth around the first joint or just anterior to it. There is no palatal wall contraction. Group 3, the thumb placed fully into the mouth in contact with the palate as in group 1 without any contact with the mandibular incisors. And lastly, the group 4 is the minimal one in which the thumb does not progress into the mouth. There is just contact with the lower incisor at the level of thumbnail. Next are the stages. So they are more classified into 3 distinct stages, that is phase 1 and 2. Phase 1, as I have already told you, we consider it is normal and insignificant. The problem of thumb sucking usually resolves by the end of this phase, and the parents are asked to ignore this habit. Phase 2, it's considered significant from 3 to 6.5 years of age, and the treatment is to correct the anxiety related to the habit, and it's the best time to consider or avoid or development of fully dental problems. And lastly, the phase 3, here the habit is associated with malocclusion. And as I already told you, any habit is affected with the 3 concepts, that is the FDI concept: frequency, duration and intensity. Next, another important term is the Dunlop's beta hypothesis. This was given by Dr. Knight Dunlop of Johns Hopkins University. Okay, so what it says is, that there should be a conscious purposeful repetition involved. So what it says is, clinically the child is made to stand in the mirror and look at himself when he's or she's sucking his thumb. So it is says that due to conscious and purposeful repetition, the habit automatically drops. Next comes the treatment. So the treatment is divided into 2 phases of any habit. First is the reminder, and next is the corrective therapy. Reminder therapy is the one to remind or want to break the habit. but the patient is unable to do so. So it involves certain chemical and restrictive methods. And lastly, certain intraoral appliances. And next is the corrective therapy. Corrective therapy is aimed at correcting the developed malocclusion. So it involves like expansion appliances like quad helix with spurs. So Pinkham divided into three stages. First is the reminder therapy. It says that there is from 3 to 7 years, not according to Norton and Jelen, there is a three-stage alarm system. So what are the three stages? First is tapping of the offending digit. Second stage is bandage is tied on the elbow of the arm of the offending digit. Third is the bandage is tightened if the habit persists. Second is the reward system, and lastly is the appliance therapy. But for that the child should be approximately 7 years of age. So what are the appliances? There are tongue spikes, guard, and rakes. And fixed appliances are the quad helix, hay rakes, and maxillolingual arch with the palatal grips. So these are the images of the appliances. Very important for your exam. So this is a removable tongue grip. If you can see, there is an acrylic plate and there is a presence of hooks for the appliance to get retentive. So this is a fixed palatal grip, presence of bands and a soldered wire. Okay. So for how long a palatal grip should be worn by the patient? So approximately 6 months or longer. And subsequently, with each appointment, as the habit is weaned off, the grips are removed slow at each and every appointment. Next, for correction of posterior crossbite, this is a quad helix appliance. Next is a very important image of the bluegrass appliance. It's a fixed habit breaking appliance given by Haskell and Mink in the year 1991. It has a roller attached here. What are the features of the thumb of the child? So the typical name or the name given to such digit is a dishpan digit. It has a reddened thumb. The thumb is exceptionally clean and there is a deposit of fibrous callus along the nail beds. Okay. So till now we have discussed non-nutritive sucking. So what is a nutritive sucking? Nutritive sucking involves breastfeeding or bottle feeding to obtain nutrition. So what is breastfeeding? It involves rapid mandible protrusion and buccal mechanism simultaneously with alternative contraction and relaxation of these muscles so as to obtain the milk. Subsequently, it is replaced by bottle feeding. Now, bottle feeding is of two types, that is first through non-physiologic or conventional nipple. So it is the end is against the posterior pharyngeal wall. So it has a very long nipple in which the milk is directly released inside the digestive tract, reducing the period of redigestion. The flow of milk is too rapid and the mouth is held wide open. So there is a greater demand of the buccinator mechanism. The sucking is now converted into suckling, which later leads to various orthodontic problems. So what is suckling? Suckling is basically small nibbling movements of the tip. Okay, so it is basically small nibbling movements of the lip. Here, the tongue is in contact with the lip, and milk is posteriorly with the help of the milk is directed posteriorly with the help of grooves. Okay. Now, as the age advances or as the child gets matured, This suckling is now converted into sucking. So how it's seen, it involves the forward movement of tongue under the flat surface of the nipple. Now the nipple is drawn upward and backward towards the palate. Now the child has to work and exercise the lower jaw. The posterior part of the tongue awaits milk as it pushes into the esophageal area. So now the milk flows by the peristaltic action of the tongue and the cheeks. And the flat shape of the nipple, this flat shape improves the lip seal. Example, it's a function of this such a nipple is a latex nuke soggle nipple. Okay, so basically, as you can see, in suckling there is greater activity of the lip or the lip muscles, which gets converted. Now there is increased activity of the tongue muscles. Okay, so this is the difference. Suckling from the breast, feeding from the bottle. So suckling involves active process, feeding is more passive activity. It requires the participation of both mother and the infant. It is not dependent on the mother. It creates a hermetically sealed negative pressure chamber within the mouth. It creates a partial neutral pressure within the mouth. Position and stabilizes the nipple, centrally draws the tongue under the mother's lactiferous tissue, and the peristaltic action of the tongue propels the milk backward. Here, the milk flows into the mouth without a tongue action, even if the lips are sealed around the nipple and the tongue action is prevented. Okay, now this suckling activity, if it persists inside in the mature swallow, leads to the development of tongue thrusting. So what are the characteristics of infantile swallowing pattern? In this, the jaws are apart and the tongue is between the gum pads. The mandible is stabilized by the contraction of the seventh cranial nerve, which is intersposed between the tongue. Now, the swallowing is guided by the sensory interchange between the lips and the tongue. So this is an infantile swallow. The tongue is between the gum pads. Okay, so there is absence of any lip seal. Now the lip seal is provided by the active contraction of the lip muscles. In mature swallowing pattern, what happens? The teeth are now in occlusion, so the tongue retracts back. Okay, now the mandible is stabilized by the help of the masticatory muscles supplied by the fifth cranial nerve, that is the trigeminal nerve. Now the tongue is against the palate, above and behind the incisors, and there is minimal contraction of lips during the swallowing pattern. This is the image. So what happens during tongue thrusting is, if this infantile swallowing pattern, as I have told you, persists in the mature swallow, leads to development of tongue thrusting. Okay, now this transition from infantile to mature swallow occurs after 6 months with the eruption of teeth, beginning with the eruption of primary incisor. And mature incisor swallowing generally develop by 18 months, some say by 4 to 5 years, when full occlusion is established. So like swallowing pattern, there is a chewing, mature or adult chewing pattern as well. Okay, so how it's different? So in adult chewing pattern, the jaw opens straight down, moves laterally and brings the teeth into the contact, whereas a child moves the jaw laterally on opening. So this transition from juvenile to adult chewing pattern occurs with the eruption of permanent canine. If you remember, canine guided occlusion. That is by the age of 12. So when the adults who do not achieve this normal function of the canine teeth because of severe anterior open bite retain the juvenile chewing pattern. So chewing pattern and swallowing pattern are different. So as I was saying, tongue thrust is swallowing as placement of tongue tip between the incisors during swallowing. It's the most deleterious of all habits. Okay, so what are the causes? First is maturation factors, as I already told you, prolonged thumb sucking and retained infantile swallow. Next are some anatomic factors like large tongue or narrow oral cavity, enlarged adenoids or tonsil, leading to the tongue being pushed forward, adaptive behavior due to the presence of spacing between the teeth. So if there is spacing between the teeth, the tongue will protrude forward so as to close this space, so as to provide a seal during swallowing. Next, classification of tongue thrusting. So Moyers classified it as Simple tongue thrusting, that is teeth together swallow, usually associated with history of digit sucking. Complex tongue thrusting, that is teeth apart swallow, in which there is a buccal occlusion is deranged, which is associated with chronic respiratory issues like mouth breathing, tonsillitis, and pharyngitis. And third is retained infantile swallow. Backline classified it as anterior and posterior tongue thrusting. Posterior is mostly lateral due to the missing teeth. So this is a anterior tongue thrusting, and this is an image of a lateral or posterior tongue thrusting. James Brandon Hall classified into four groups. First is a non-deforming tongue thrust. Second is a deforming anterior tongue thrust, subclassified into three groups like anterior open bite, so anterior proclination, and posterior cross bite. Type 3 is deforming lateral tongue thrust, posterior open bite, posterior cross bite, and deep overbite. Type 4 is a deforming anterior and lateral tongue thrust associated with anterior and posterior open bite, proclination of anterior teeth, or posterior cross bite. Now, a very important table with respect to tongue thrusting habit. Now, this table summarizes all of the features of tongue thrusting which I have just told you. So, according to Moyes, as I have told you, it is classified into simple, complex, and retained infantile swallow. Simple tongue thrusting is associated with the history of digit sucking. Complex is due to certain anatomic factors. So, infantile swallow and retained infantile swallow are same. Okay, so in infantile swallow, the tongue is between the teeth or gum pads. The mandibular stabilization is with the help of seventh cranial nerve, that is the facial nerve. The teeth together swallow is absent, teeth apart. The lip and mentalis contraction is there. There is no enlarged tonsils in it. Okay, now coming to the mature swelling pattern, it will be exact opposite to the infantile swallow. Now in simple tongue thrusting, which is associated with the history of digit sucking, the tongue is not between the teeth. In complex tongue thrusting, it is between the teeth. The mandibular stabilization is not by the facial nerves, whereas in complex it is by the facial nerve. There is a well circumscribed open bite located in the anterior region. It's generalized diffuse open bite. Teeth together swallow present. In complex, it's teeth apart swallow. There is lip and mentalis activity present in both of them. Complex is associated with certain anatomical obstructions leading to protruded tongue. The prognosis is worse in retained infantile swallow. It is poor and fair in simple. The intercuspation is precise, it's poor, it's absent, only most distal teeth are in contact. So this is the image of an simple tongue thrust with anterior open bite. Complex tongue thrust now due to the presence of an inflamed tonsil. Retained infantile swallow, there is absence of any intercuspation in any of the teeth, and complex tongue thrust. Look at the blank and facial expressionless appearance of the child. Features I've already told you. There is open bite, either anteriorly or posteriorly, proclination of upper anterior teeth, protrusion of anterior segment of both the arches, narrow and constricted arches, the muscular activity to bring the lips together. So notice the normal position of the tongue. So during rest, the dorsum touches the palate while the tip rests against the cingula or fossa of the mandibular incisors. Okay, management. So management begins with the muscle exercises. So there are various scientists who are given different. First are the Barnett tongue positioning exercises in which the tongue touches the incised papilla. The swallowing is by touching the tip to the papilla first with the lips closed and then apart. Andrews, he said that swallowing 20 times before meals and with water in mouth and mirror in hand. During swallowing, the lips and teeth should be closed and the tongue tip should touch the incisive papilla. Single elastic swallow by Gardner, or tongue tape and speech exercises, and double elastic swallow with the middle of the tongue and speech exercises. Lip exercises are lip pull exercises to strengthen the lip and lip over lip exercises. Next comes the appliance management using bilateral grips and spurs and roll. Corrective therapy involves correcting the etiology if it's the obstruction or is there an anterior spacing superimposed with the tongue thrusting habit. Question 4 exercise is used for tongue thrusting. What is the 4S exercise? 4S stands for spot, salivate, squeeze and swallow. Okay, so these are the two habits which we have discussed. Next comes the mouth breathing habit. So in the beginning, I have told you the newborn infant is an obligatory nasal breather. So what happened? So in an altered respiratory pattern such as breathing through the mouth rather than the nose changes the posture of the head, jaw and tongue. So why does this alteration occur? So this transition to oral breathing occurs when the exchange rate goes above 40 to 45 liter per minute. Okay, that is when the nasal resistance reaches about 3.5 to 4 centimeter of barometric pressure per liter per minute. The breathing switches over from nose to the mouth. Okay, so what happens when this switch over occurs from nasal breathing to mouth breathing? It alters the equilibrium pressure on the jaws and teeth, which affects both the jaw growth and the tooth position. So for the patient to breathe through the mouth, what he has to do is open the jaw. When the jaw opens, the lower jaw, that is a mandible, drops downward and along with the tongue also goes back. And subsequently, the patient has to extend the neck or flex the neck back like this. So what will happen if these changes are maintained? What will have the skeletal effect on such changes? First, the anterior or the lower anterior facial height would increase. Okay, now the lower mid jaw is open, so there is an increase or a lack of intercuspation between the posterior teeth. The posterior teeth will also supra-erupt, leading to further increase in the lower end facial height. Next, there will be an increase in the vertical growth of the ramus, which will further increase the open bite anteriorly and overjet as well. Next, the tongue has dropped backward, so again a disturbance in the buccinator mechanism. If the buccinator mechanism is disturbed, there will be a strong buccal wall contraction leading to the narrowing of the maxillary dental arches. So what are the causes of such mouth breathing? First is mouth breathing can be intermittent and at night, also known as oronasal breathing, which can be due to obstructive habit like anatomical obstruction. What are the causes? Like deviated nasal septum (DNS), narrow maxilla, any inflammation of the tonsil, allergies, obstructive adenoids, localized benign tumors, or congenital enlargement of the nasal turbinates. It can be habitual as well, and lastly due to air hunger. So what is the separation of lips without mouth breathing? That is, can be due to anatomically short upper lip, or subsequently can be due to interference by the upper incisors like protein anterior teeth. So what are the common causes of reduced nasal flow? As I already told you, first, frequent respiratory infection like swollen nasal mucosa, enlarged tonsil and adenoids. Like DNS, that is deviated nasal septum, and lastly constricted maxilla leading to decreased nasal width. All of these can lead to mouth breathing. Now mouth breathing will lead to extended head posture and downward and anterior tongue posture position leading to lower mandibular posture. Okay. Subsequently, another theory to explain this is the stretch theory given by Solow and Kriebel. So, according to it, their obstruction to airway. He gave the importance to obstruction to airway as a major causative factor in determining facial morphology and head posture. So what happens? Now there is obstruction to the airway which sends a neuromuscular feedback to the central nervous system to the brain. Now the brain leads to postural changes. What are the postural changes? The head is extended back, there is a flexion in the neck leading to the stretch of the soft tissue. Now what this stretch is opened, there is differential forces occur on the skeleton leading to the morphological changes. Now this cycle again keeps on repeating. So what are the clinical features? As I already told you, short upper lip, flaccid lip. Next are the adenoid facies, and a very important term given by Dr. C.V. Toms, in which there is a long face, there is a contracted upper dental arch, exposed but not necessarily prominent incisors. There is anterior margin gingivitis. Why? Because of the prolonged opening of the mouth leading to drying of gingiva with anterior open bite, receded mandible, vacant facial expression, open mouth, short pouting upper lip, and narrow anterior nail. Lower lip is heavy and inverted. There is short and flaccid upper lips and associated habits. So this is the image of adenoid facies. How to diagnose it? First is the mirror test. A two-way mirror is kept between the nose and the mouth. Whichever side gets fogged up highlights the mouth breathing. Next, butterfly test. A butterfly shaped cotton wisp is kept. Next, rhinomanometry. It's considered as a gold standard, also known as induction plethysmography. Studies the characteristics of the airflow, which estimates the airflow through the nasal passage and nasal resistance. Mirror test, as I already told you, a double-sided mirror is kept to check the fogging. Massless butterfly test or a cotton test can be used for diagnosing mouth breathing. Kinesiography. Kinesiography is not a direct test to diagnose mouth breathing, it's an indirect diagnostic method which records the postural rest position of the mandible in 3 dimensions. So through the postural rest position of the mandible, it is estimated whether the patient is breathing through mouth or nose. Lastly, cephalometrics. So in cephalometrics, which is the analysis, that is the McNamara's analysis, is used to estimate the nasopharyngeal space. Next is the SNOT. Another very important, it stands for simultaneous nasal and oral respiratory technique. So basically it consists of a very large glass chamber which has a very series of walls and flow meters and air pressure calculators used to measure the respiratory activity of the patient. So question, mouth breathing can be diagnosed by all except, so as I already told you, kinesiography is an indirect method. It diagnoses or it tells us about the posture of the mandible. It is not used for diagnosing mouth breathing. Okay. Next is the management. So the management starts with determining the first of all the cause. So if the cause is adenoid obstruction, so adenoidectomy with or without tonsillectomy is the first line of treatment. Now, Another very important point is it should not be performed too early, less than 4 years or in primary dentition. Okay. Next is if there is a skeletal constriction, a rapid maxillary expansion should be done to reduce the nasal resistance and promote nasal breathing. Next is a preventive and interceptive management. So the habit usually ceases at puberty or after it due to the increase in size of the passage during periods of rapid growth. Okay, so why? The lymphoid tissue regresses in size as after puberty. Okay, remember the Scammons growth curve. So how to intercept the habit? It can be intercepted with the help of oral screen or oral shield. So it corrects the simple flaring of the maxillary anterior teeth. This is the image. It's a habit correcting appliance. Also acts as a simple myofunction appliance as well by stretching the oral vestibule and brings about indirect expansion. How? It is based on the functional matrix theory. Stretch the soft tissue and automatically the hard tissue follows it. Okay, there is a modification of this oral screen by Hodge. So Hodge modification for lip exercises incorporation of a metal ring. Okay, so this metal ring can help in the development or increase in the lip length. Next is breathing holes are present initially inside the acrylic so that the patient can breathe through the mouth, and subsequently as the habit is cessated, these holes are filled with acrylic with time so that the less air enters to the mouth, and finally all the holes are closed. Next is a muscle therapy. It is aimed at to achieve mouth closure. So during daytime, the patient is advised to hold the pencil or paper between the lips, and during night time tape the lips together with surgical tape and habitual mouth breathing. Lastly, sheets of paper can be placed between the lips. Next is a button pull exercise. Thread is passed through the buttonholes and the patient is asked to place the button behind the lip and the thread is pulled. Now draw the upper lip over the upper incisor and the hold under tension for a count of 10. So a button along with the thread is placed inside the mouth and the patient is asked to pull that thread so that the lip seal improves. Next is lip sucking and lip biting. The first is the image of lip sucking and second is the image of lip biting. So lip biting is commonly associated with the signs of anxiety or a large overjet like in class 2 deafened malocclusion. So what happens in this is, as we know, the lower lip is trapped behind the proclined upper incisors and there is excessive activity of the mentalis muscle to attain the lip seal during functions of swallowing. So the consequence is there is upright or lingually inclined lower incisor which further worsens the malocclusion. How? Because it further lead to increase in the overjet. Next is lip biting. So lip biting could be due to injury on the lower lip, ulceration, hematoma and other painful condition and cracking. Okay. So how is lip sucking and lip biting different? So lip biting, as I've already told you, is associated with increased overjet like class 2 deafened malocclusion. So it is often associated with a bit of lip trap. Okay. Now this lip trap and overjet could be the outcome of the lip sucking, or overjet could lead to lip trap and worsening of the malocclusion. So how to correct it? So it can be corrected with the help of a lip bumper which prevents lip pressure on the lower incisors. The labial position of the incisors gets normalized with the tongue pressure and the long large snip can be gained with the help of this method. So this is the image of a lip bumper. See this acrylic shield which is present constructed at some distance away from the lower incisor. So what happens is this shields the mentalis muscle activity on the lower incisor so that the lip or the overjet, the lower incisors can develop or accordingly shielding away or taking the effect of the hyperactive mentalis activity. Next is the nail biting, also known as onychophagia. So it involves putting one or more fingers in the mouth and biting on nail with the teeth. It often starts after 3 to 4 years of age and increases with childhood to adolescence and then decreases in adulthood. It is most commonly associated with TMJ pain and dysfunction. Common etiologies involve emotional tension, genetic and environmental factors, and certain psychiatric disorders like ADHD, positional defiant disorder, and separation anxiety disorder. What are the common complications? First is gingival infections like swelling, abscess, increase presence of Enterobacteriaceae and Escherichia coli. Trauma to the nail bed or nail matrix or infection can cause the increased rate of nail growth, nail bed shortening, herpetic whitlow, acute paronychia, and acute osteomyelitis. Apical root resorption, malocclusion, and crowding of incisors. So, what are the management? First involves non-pharmacological management, which involves psychological counseling, applying bandages to the patient's finger, hands-on activities such as handicraft or music instruments, and enhancing child's self-confidence and self-esteem, or a multidisciplinary approach involving the combination of the above factors. Next is the pharmacological management, which involves the use of serotonin receptor uptake inhibitors, TCA tricyclic antidepressant, and N-acetylcysteine. Last is the bruxism. So bruxism involves, what it means is grinding of teeth for non-functional purposes. So basically it is nocturnal or nighttime grinding is known as bruxism, and daytime grinding is known as bruxomania. So what is the etiology? It's mostly psychological and emotional stress. There can be occlusal interference. Pericoronitis or periodontal pain can also trigger it in some patients. Features will be, there will be presence of occlusal wear facets on the teeth, fracture of teeth and restoration. In severe cases, mobility can also occur, tenderness and hypertrophy of the masticatory muscles, muscle pain when the patient wakes up in the morning, TMJ pain and discomfort. Management involves psychological counseling, occlusal adjustment, night guards, and occlusal splints. So these are the oral habits, okay, which I have discussed them in brief. Okay, just go through them. If anyone has any doubt, can write in the comment section. It's a very important topic for your NEET exam. In each exam, there is image-based question or some or the other form of question which comes based from this topic. Very important from both ortho and pedo point of view. The pattern of the exam, everything is now clear with the coming of the prospectus. Now the only job remaining is for you guys to study and crack the exam. If anyone has any doubt, you know where to reach us. More question, kindly discuss. Yes, certain questions I have taken up related to this topic. From the next upcoming sessions, I will be taking up discussions on MCQs only. Now I won't be covering up theory topics until your exam. Theory will resume post your exam. Now I will be covering up mostly MCQs in the next sessions which I have. Okay, because theory is also important because certain students have been messaging me. That's why I have taken up theory topics. Okay, now your exam dates have come, so I'll be doing only theory MCQ now. And theory related to that question only, not in detail. Sir, pulse is enough? No, pulse is not enough. Okay, my advice is first cover all the notes and then start with MCQs. Notes should be done thoroughly, itne thoroughly that at night also if someone wakes you and asks you a point, you should be well versed with it. First step notes, next step MCQs. And MCQ, not only pulse, any book which you can lay your hand on. Okay, begin with pulse, then class, do class test, class. There is a DAMS question bank is also there. Complete that as well. Give grand test. Okay, complete subject wise, complete past paper enough for selection. No, as I've already told you, nothing, no one such thing is enough. The pattern nowadays is not of such question that only repeat is coming. They are forming new questions and the questions are based on clinical in knowledge now. Okay, there is a clinical case based scenarios are coming in your exam. Now this case based scenario, clinical scenario is coming from your combination of theory set. It's not something कि कुछ नया आ रहा है एग्जाम में apart from the all facts which we are discussing, but the basic theory is there and they are asking you the application of that theory in your exam. Okay, so yes, past papers are important so as to grasp the basic crux or the pattern of the exam. Okay, but the first and foremost is to understand your theory and your notes. Next step is solve the MCQs to gain confidence. Okay, and third step is to give exams or test papers, solve question test papers in the requisite time so as to know your ranking and where you stand among others. Any more question? Okay, so as I told you in the last session, keep up away from false information, misinformation. उसने ये कह दिया, उसने ये कह दिया, ये कह रहे हो. Okay, exam जब होना था, as I told you last time also, they will give you 1.5 months and they have given you. Last time also someone asked me when will the exam happen. I also told them March end or April first week. Now it's happening on April 19th. So everything is, every time this occurs, they give you in ample time. They have given you ample amount of time. Just keep up away from misinformation कि ये आ चुका है, ये आएगा, पैटर्न चेंज हो गया, जो भी होगा, every information will be conveyed through NBE website. Okay, no one, I repeat, no one has any such kind of inside or information. Okay, all of every bad thing, do not create panic. Fill up the form आराम से, take your time, read the prospectus, read all the documents which are required for filling up the form, go through the ICC internship completion date, everything, and keep a copies. Yeah, what we used to do is keep a soft copy, scanned copy of all of these documents in your laptop so that it's easy for you to fill up. Okay. That's all from my side. Okay, if anyone has any other doubt, you know where to reach us. Please I again repeat, now it's high time to just wind up everything. Complete your theories. कोई अब इतना ये भी नहीं है कि एग्जाम 30th जनवरी को होना था. They have given you 3 months additional for that portion. Chances of appliance based question in the कहाँ से पढ़े. Most of the appliance based images I have already taken in my lectures. Okay, most I can say I have more than 95% I have covered. Okay, so appliances images I have already covered. If furthermore in the upcoming sessions I'll take up MCQs and again show you those images, not to worry. In the previous session, I have taken image-based questions, revision question series, and everything I have taken. They are all available, still available on our eMedico's app as well. Okay, I put them on the test and note section, all the images. Revision session which occurred in January, again I showed you the images. All of them are still available. You can go through them. In the class lectures I have taken, in the test papers, they are there. Okay, I can assure you 90 more than 95%, less than 2-3% कोई कहीं से एकदम आ जाए तो I cannot you say that. Okay. Okay, so I think there is no more question. I'll close the session now. Thank you for your time. FP doubt group बंद हो गए sir. No, it's still there. We have a WhatsApp group as well. We FP doubts, you can post your doubts on the Facebook and you can post your doubt on the WhatsApp as well. इस पे आपका आता नहीं, otherwise you can get in contact with the DAMS coordinator and all that. I am not understanding why you are facing such trouble. We still have Facebook group where we answer doubt. We have also have WhatsApp group. You can post your doubts anytime and all the faculties are there on all these groups. Okay, so I'll stop.